Hello, this is Stephen Holloway. We're going to be discussing coronary artery disease and acute coronary syndrome. This is part of Module B for Nursing 202. Coronary artery disease can be broken down into two sections: chronic stable angina pectoris and acute coronary syndrome. Acute coronary syndrome is then broken down further into unstable angina and myocardial infarction. When we look at the definition of chronic stable angina, it's defined as chest discomfort that occurs with a moderate to prolonged chest discomfort that occurs when the patient has had moderate to prolonged exertion, and it's in a pattern that's familiar to the patient. In other words, the patient would know, if I climb 2 flights of stairs, I have chest pain. I can go up 1 flight and be okay, but if I try to go up 2, I'll have chest pains. The etiology of this disease process is caused by a fixed atherosclerotic plaque that causes a temporary imbalance between the myocardial oxygen demand and the oxygen supply going to the myocardium. Typically, the treatment for this is rest, nitroglycerin, beta blockers, calcium channel blockers, aspirin, and Plavix. Acute coronary syndrome is basically described patients. It's believed to be the atherosclerotic plaque as well, and in coronary artery disease, that plaque ruptures, resulting in platelet aggregation, leading to the development of the thrombus. Now, because of that thrombus, what we now have is a blockage of that coronary artery, so blood can't get through. So again, we have that oxygen deprivation to the area, so we have a oxygen deficit at the muscle. So when we look at acute coronary syndrome, it's broken down into 3 areas: ST elevation MI, MI being myocardial infarction or heart attack, and you'll hear the term STEMI. We also have non-ST elevation MIs, which is called a non-STEMI. When we're talking about ST elevation, we're talking about looking at that patient's EKG. What we should see in infarction going on is an elevation of the ST segment of the EKG of that QRS complex. We'll see the elevation of the ST segment, and that indicates that ischemia and necrosis is going on at that site. The other section is unstable angina. Unstable angina will give you some ischemia, which is more depressed T waves looking, but will not have the elevation of the cardiac markers, biomarkers, that you'll see with an MI as with the ST or non-ST elevated MI. Now, understand that basically before you start to see blockage of blood flow, you need basically a 40% blockage has to be in place before you start to see any problems, anything's going on with the patients. One of the things that, and when physicians are doing cardiac cath looking, they will not actually do a procedure such as an angioplasty or a stent unless that vessel is at least 60 to 70% blocked. But that percentage of blockage will lead to the symptoms these patients are having. The greater the degree of blockage, the greater the symptoms are going to have, patients going to have. Unstable angina is chest pain that occurs at rest or with minimal exertion. At rest or with minimal exertion. The pain may last longer than 15 minutes. It may last less than 15 minutes. Typically, unstable angina is poorly relieved by nitroglycerin, where stable angina is typically relieved by nitroglycerin. Between 10 and 30% of patients with unstable angina typically progress on to having an MI within 1 year of the diagnosis of unstable angina. So these patients have that blockage. It's already there. It's just a matter of time before they do that. Patients with a diagnosis of unstable angina, about 29% of them die of a myocardial infarction or a heart attack within 5 years. Now, unstable angina is broken down into 3 categories: new onset, variant or Prince Meadows angina, or pre-infarction angina. The new onset basically describes the patient who's had his or her first symptoms. It's usually after exertion or with increased demands on the heart. These patients may have never had chest pain before and may have this and come into your emergency department, your clinic, or whatever, complaining of these chest pains. Very difficult at that point in time to determine whether this patient is having an MI or it's just this angina. You're going to follow through with these patients just like you would, as we'll talk about a little bit later, in treating the patient with an MI. You've got to go through that whole process, because at this point you do not know whether it's angina or whether it's an MI going on. Variant or Prinzmetal's angina is chest pain or discomfort resulting from coronary artery spasm. It typically occurs after this patient has rested for a while. For some reasons, the coronary arteries begin to spasm, and these patients will get the chest pain because these spasms are causing blockage of blood flow to the myocardium, leading to ischemia, which leads to pain. Many times they'll get these patients into the cath lab, do a cath, and their coronary arteries are clear. And so that's really how you get the diagnosis of variant angina. Now, pre-infarction angina basically just refers to chest pain that occurs in days or weeks before an MI. It's kind of a warning sign for these patients. So those are some of the things that you may see. Now, when we look at unstable angina, it's broken down into 4 classes. These classes come from the American Heart Association's. I got these from the ACLS workbook. Class 1, basically ordinary activity doesn't really cause them any pain. It requires strenuous or prolonged activity for these patients to have discomfort. Class 2, these patients have a slight limitation of ordinary activity. Pain may occur with walking or climbing stairs rapidly, walking uphill or climbing stairs after a meal, walking in the wind, or especially cold winds, and in the cold may cause pain for these patients, and walking greater than 2 blocks or up 1 flight of stairs at a normal pace. That would be Class 2. Patients who are defined with Class 3 have marked limitations. They have pain with walking 1 or 2 blocks, even on level ground. In Class 4, these patients have the inability to perform any physical activity without pain. So if they got up and walked from their bed to the bathroom, they would have chest pain. This little graphic just kind of gives you a breakdown of the different types of the symptoms that go along with unstable angina. The only thing is with duration of pain, even with unstable angina, sometimes it can last more than 15 minutes. But for most patients, it's 5 to 15. But you really cannot go by the time frame only. As you can see, the pains are very similar. The associated symptoms are similar. The difference is the cardiac biomarkers. With unstable angina, usually the biomarkers troponin and CKMB are within normal limits. So those are kind of the things that you will look at with these patients. Again, you as a nurse will not have to be making those decisions, but you need to understand that the patients may be diagnosed with unstable angina or myocardial infarction. Now, myocardial infarction, or a heart attack in lay terms, occurs when the myocardial tissue is abruptly and severely deprived of oxygen. This is because of blockage of one of the coronary arteries. It could be because of plaque buildup. It could be because of the rupture of one of those plaque areas. It could be from thrombus buildup in those areas. Anything that basically reduces the blood flow from 8 to about 80 to 90% in that coronary artery. So ischemia begins to occur when blood flow is reduced 80 to 90% through that coronary artery. As that ischemia, if it continues to be there, then basically an infarction will take place. Infarction is a dynamic process. It doesn't occur instantaneously. So, in other words, you don't have the dying of the tissue instantaneously, but it evolves over a period of time. It takes time for that death to take place. That's why when we start talking about getting these patients in, when we start talking about reperfusion, we have a time frame that we want to move in doing the reperfusion on these patients as we move forward. But basically, this takes place over several hours process. What's the etiology? We kind of talked about that. It's a rupture of a plaque in a coronary artery leading to the development of the thrombus and occlusion of the coronary artery. Can be from coronary artery spasms. We have had patients with the Prinzmetal's angina develop into an infarction because the spasms went too long. Platelet aggregation is another problem, and then a mural thrombi can cause those type problems. Chances of an infarction can increase based on, again, it's based on the myocardial oxygen demand and the supply. So if we're decreasing that oxygen supply going to the myocardium, the risk goes up for developing an MI. If you have a patient that has severe anemia and you overtax the heart and there's not enough oxygen getting there, you could get that. Patients who are in shock, not having blood flow to the area, that can be being a cause for an MI as well. So anything that's changing that myocardial oxygen demand and supply, where the demand is more than supply, can lead to ischemia and to an infarction. When we look at the coronary artery disease, when we look at the areas of necrosis, those type of things, and earlier I talked about STEMI and non-STEMI MIs. When we begin to develop ischemia, when you're looking at an EKG, you're going to see a T-wave inversion, then you're going to see that as that gets more and more, you're going to see that T-wave get deeper. Once necrosis begins to take place, the tissue is actually beginning to die, you will see what is called ST elevation. And this is severe ST elevation here. You can see this is the QR, and then as the S begins to come down, the S doesn't go very far till the T wave comes up to meet it. So this is ST elevation. Even though they say here abnormal Q, you do have a Q wave here where there, and a Q wave usually indicates old injury. But this elevation is what the biggest concern is. And you can see that basically with the zones of an MI, you can hear right at the center of this one is basically a severe ischemia. It is beginning to die there in these areas. Okay, the necrosis area is dead. Severe ischemia is here in this area, and it can actually recover if we get revascularization to there enough. Whether that be revascularization is through a coronary, through a PCI, percutaneous coronary intervention, such as a angioplasty, or through chemicals such as clot blusters, such as TPA, whatever we need to do to basically get reperfusion back to those areas. So in these areas here, again, the further out you move from the area. Now we hope for good collateral circulation in these areas to get more blood flow to those areas, but that's not always the case. But we can have areas, you have zones around the area that's there. If you think about a bruise and you've seen a bruise on someone's arm or whatever, the center tends to be the darker area and the colors kind of fade out as you go further away from the area. Think about that as the injury that's going on here with the heart. This is just a graphic representation, again, of what we're looking at. You have basically in the very center of the target the area of death, the infarction. The area is oxygen deprived. The damage is irreversible after an amount of time. And that's what causes the Q wave, the first downward deflection of the EKG complex here and everything. The area of ischemia is variable, may not be damaged as long as the MI doesn't extend and there's collateral circulation to the area. That's going to cause that ST segment depression. That area of injury is next to the infarct. It's viable as long as circulation remains. But we, again, the quicker we can get reperfusion back to these areas, the better it is. Now, myocardial infarction may begin in the subendocardial layer and stay there. And if it does, then this is called a subendocardial MI. If it actually progresses through all layers of the heart, that's going to be called a transmural MI. And of course, as you would imagine, a transmural MI is much more dangerous than a subendocardial MI because you're killing off more cardiac muscle in those areas. So again, it's much more a problem if you see a transmural MI. So when we look at this whole myocardial process, we've kind of talked about this. Initially, there's hypoxemia and ischemia going on. There's that lack of oxygen getting to the myocardium. That demand is greater than the supply of oxygen. And when we when this begins to happen because of the damage, you get the release of catecholamines. Now think about what happens when there's a release of catecholamines. Catecholamines are going to increase the heart rate. Okay, it's also going to increase the cause vasoconstriction. Both of those are going to increase the workload on the heart. The faster the rate, the more oxygen the heart needs. So you're going to have more oxygen demand on the heart. Also, the catecholamines are going to cause a vasoconstriction, which increases afterload, which causes the heart to have to pump harder to get the blood out to the system. So this release of catecholamines is not a good thing. This is something we have to be aware of. That's why morphine is such a good drug to use in patients who are having an MI. As I was saying, morphine is the drug of choice, and as we looked at, if you have done your module assignment already, the term MONA, M-O-N-A, is morphine, oxygen, nitroglycerin, and aspirin. Well, when we look at it, the morphine basically does a couple of things. It slows the release of catecholamines, it causes a relaxation of the vasculature, and basically helps with that whole process of myocardial oxygen demand. So that's why morphine is used as a drug for MIs. Typically about 6 hours after the infarction, we actually see that area beginning to turn blue. It's just like any other tissue injury. It turns blue, it's swollen. And think about what's going on. Because of that, you're having the different types of white cells move into that area. So it's not uncommon for patients who have had an MI to have an elevated white blood cell count. After 48 hours, sorry about that. After 48 hours after the infarction, the area begins to turn gray and has yellow streaking. Again, this is the optimal time for a lot of problems to occur with these patients, because during that time frame, that area is very weak. So you could have ventricular rupture, you can have a ventricular aneurysm in that area. Also, this area is not conducting electricity, but it's very irritable. So you could actually see ectopic electrical coming from around that area, so you could be seeing PVCs from those areas. 8 to 10 days after the MI, you begin to get granulation of that tissue forming at the edges, so you get the buildup of necrotic at the edge of the necrotic tissue is beginning to scar over. It takes about 2 to 3 months for that scar tissue to really form in those areas. Now be aware that scar tissue cannot conduct the electrical impulses. It cannot pump. It's not muscle, so it's just an area in that wall that's not functional. So you're, depending on how large your MI is, you're losing muscle tissue, so you've decreased your pumping power or your cardiac output because of that issue. This just kind of shows some of the different areas. Time basically here at onset, you can begin to see the area here. You can see the infarction beginning to move a little bit more after 30 minutes, up to an hour, and then 24 hours you can see the deadening. Okay, now again, this is going all the way through, so the extent of injury increases over time. So we really want to try to get these patients in and get them treated as early as possible to prevent these problems. We want to get revascularization as quickly as we possibly can. We're going to try to see if this works. I won't guarantee it, but here, let's give this a try.
Classic symptoms of coronary ischemia include substantial chest pain radiating to the left arm and jaw, as well as diaphoresis.
Don't you just love their diaphoresis on the patient?
The coronary vessels are specialized in that they supply the active heart muscle with oxygen-rich blood. Each coronary coronary vessel supplies a different region of the heart with blood as delineated by the 3 different colors used here. The 12-lead electrocardiogram, or EKG, records cardiac conduction in the various regions as shown. The right coronary artery, in blue, is represented by leads 2, 3, and AVF. The left coronary artery, in gray, by leads V1 through V4. And the left circumflex artery in tan, by leads 1, AVL, V5, and V6. In this close-up view of a single QRS complex and T-wave, note the relatively flat ST segment and the upright T-wave. Both are normal and indicative of normal conduction. A close-up of the right coronary artery allows a cross-sectional view of plaque development within the vessel. A lengthwise view shows the same, and the narrowed lumen is seen to partially obstruct blood flow through the coronary vessel. The region of the heart dependent on that vessel for oxygen-rich blood becomes somewhat deprived. The tissue fades in intensity to represent this ischemic change. Note the red-line variation in the EKG tracing that demonstrates an inversion of the T-wave. This is one of the characteristic EKG changes seen in areas of the heart that are deprived of normal oxygen-rich blood flow. One of the first-line medications for patients with cardiac ischemia is aspirin, which should be administered soon after the onset of symptoms. The normal adult dose is 325 milligrams. It can be chewed and swallowed for fast absorption. Aspirin is absorbed into the bloodstream and inhibits blood clotting by preventing platelet aggregation. Another common medication used to treat coronary ischemia is nitroglycerin. Nitroglycerin can be given by multiple routes, but the sublingual route is common because it permits rapid absorption of the medication.
So that kind of talks a little bit about the MI and a couple of the medications. Remember that basically we talked about with the MI that it is just a change in oxygen demand and supply. So you have more demand than you have supply. We've seen that. So here's what kind of the crux we're going to talk about as we begin to look at what we're going to do for these patients. And basically this is the ACLS algorithm for treating chest pain and evaluation of chest pain. Now I know that's a lot, and so we're going to go ahead and move to kind of the immediate emergency room assessment that you may be involved with. Chest pain evaluation, of course, these patients are going to come to you. The majority of them are going to come to you from EMS. EMS typically will have already started the oxygen, started giving them a dose of aspirin, and probably have already given them nitroglycerin. And typically they're going to have an IV in place before they get to you, and you'll have good vital signs. Also EMS, most EMS now will have a 12-lead EKG, which will give the physician a chance to look and see if there's any areas of ischemia or infarct before the patient arrives to your location. But basically, if the patient walks in off the street, of course, you're going to get, once they say they have chest pain, you're going to get them back immediately, get a set of vital signs, evaluate the oxygen saturation. Even though it says 90%, most ERs are going to go ahead, even if the sats are that at 90%, they're going to go ahead and put these patients on oxygen. The better saturated I have the blood that's going to that muscle, the more oxygen can be released in that area. So the more oxygen I get to that ischemic area, the better it is. Got to have IV access. I really want to make sure I have IV access before I give nitroglycerin, because you understand that nitroglycerin is a vasodilator, and that nitroglycerin is basically going to cause the patient's blood pressure to drop. If it drops it too much, then I've got IV access to go ahead and bolus that patient and take care of that. Again, EKG is very important, a targeted history. And we'll talk about the fibrinolytic checklist as we go along. All of this is kind of being done at the same time. Over here, you're seeing kind of the MONA, morphine for the M, oxygen for O, nitroglycerin for the N, and then aspirin for the A. But again, it's not necessarily in that order of morphine and everything. Typically, oxygen's your main drug you want, then aspirin, nitroglycerin, and then morphine if the patient is not relieved by the nitroglycerin. But all of this is being done kind of at the same time. You're never going to be, unless you're working in a very, very small hospital, you're never going to be alone trying to take care of this. You're going to have help with these patients. When I was the officer in charge of the emergency department out at Fox Army, I had some great medics working with me. As a matter of fact, one of them was Dr. Miller's brother. But, I mean, a patient walked into my emergency department, complained of chest pain. Basically, within 10 minutes, that had that patient in a bed, IV started, EKG done, blood work drawn, and the physician was in seeing them in that amount of time. So we basically knew what to do with a chest pain patient, and it was teamwork. It was teamwork. One person was worried about getting the oxygen on, another person was starting the IV, drawing the blood, another person was doing the EKG, and another person was getting a quick history on that patient. So it's really a team-type effort in taking care of these patients. I'm not going to ask you on the test to put in order, are you going to do oxygen, aspirin, nitroglycerin, and morphine first? Because it is very dependent on the patient's situation. Again, this patient may be allergic to aspirin and you're not going to give aspirin. This patient may have a history of peptic ulcer disease. You're not going to give the aspirin. They may have taken an erectile dysfunction drug, so you're going to be very cautious about using nitroglycerin on this patient. Their pressure may be less than 100, so you're not going to give them nitroglycerin. So I'm not going to really ask you which one you need to do first. You need to understand that these are part of the treatment process in taking care of a patient with an MI. It is very important to get IV access. It's very important to get that 12-lead EKG, and the fibrinolytic checklist is going to be important as well. In large hospitals where you have cardiac cath available in the hospital, that's probably your gold standard versus doing the TPA. But in smaller hospitals like Marshall South or Marshall North, or maybe even Lincoln County in Tennessee, you don't have cardiac cath capabilities and in-house. So you're probably going to try to get that reperfusion using a fibrinolytic versus trying to do a PCI process. Again, this is kind of looking at some of the different types of other things that you may be seeing. If the patient has ST elevation or presumably a new left bundle branch block, you're strongly suspicious for an MI, especially an ST is called a STEMI, an ST elevated MI. Some adjunctive therapy you might see. These patients may be put on a beta blocker, maybe put on Plavix, and maybe started on heparin at that point in time. If the time from onset of symptoms is less than 12 hours, then we need to start reperfusion strategy on these patients. One of the things that you'll see are the standards. The American Heart Association standards is basically from the time they hit the emergency room door to the time they hit the cath lab and the balloon is up on them is a goal of 90 minutes. If you don't have that available, the goal is to have fibrinolytic therapy started on these patients within 30 minutes of them arriving to the emergency room. So those are some of the things. Now, as we move along with these patients, ACE inhibitors are going to be used with them, and typically that's going to be started within 24 hours of symptoms. Now, statin therapy, again, that's probably going to be more of a discharge type process on these patients, so that's something you're not typically going to worry about in the emergency department. But as you go on from those areas, then you're going to be doing there. So you're asking, what if it's greater than 12 hours? Typically, if it's greater than 12 hours, most of the time they may start these patients on a heparin drip, but then it's just observation, because by that time tissue is dead. Getting reperfusion therapy is really not going to benefit that patient. All of it's now beginning to move into monitoring for complications of the MI and for beginning rehabilitation therapy on that patient. Here's a look at the fibrinolytic checklist. And this is very straightforward. Most hospitals will have their own form for these that you'll fill out. But basically, step one is the patient experienced chest discomfort for more than 15 minutes and less than 12 hours. If it's yes, you move down. EKG show a STEMI or a new left bundle branch block. Yes, then you go ahead and go into looking at the contraindications of the fibrinolytic therapy type process. If it's no to these, you stop and then you kind of move on to a different algorithm. Things we're going to look at is, again, the blood pressure. If it's greater than 180 systolic, more than 110 diastolic, that may be a contraindication, but we can lower that blood pressure. Again, beta blockers, labetalol, can be used a lot of time to go ahead and lower that blood pressure. If there's a difference between the right and left arms of more than 15 millimeters of mercury, that can be a contraindication. If they've had some sort of central nervous disease, structural defect, they've had a stroke greater than 3 hours or less than 3 months ago. This fibrinolytic therapy is also used for the stroke patients, and you'll be talking about that next semester. Have they had closed head trauma, facial trauma within the previous 3 months? Have they had major surgery within the last 6 weeks? Any history of a GI-GU bleed? Are they on blood thinners? Do they have clotting problems? Was CPR done on this patient and it was longer than 10 minutes? If it's longer than 10 minutes, pretty much they're not going to move forward with fibrinolytic therapy. If it's a female and they're pregnant, it cannot be used. And typically, if they've got advanced cancer, severe liver, kidney disease, this medication is not going to be used. These you're going to look at. If any of these are in place, heart rate's greater than 100 and systolic less than 100, these patients really need to have a PCI, percutaneous coronary intervention, done. If they have pulmonary edema, any signs of shocks or contraindications to fibrinolytic therapy, immediate transfer to a facility, stabilize and transfer to a facility that has cardiac cath capabilities. So how do we actually diagnose an MI? Pretty straightforward, really, with 3 different types of processes. The signs and symptoms, how that patient comes in, what they complain of. Most of us know the typical signs and symptoms of a heart attack is substernal chest pain, described as pressure with radiation to the left arm, shoulder, and jaw. Now, Patients who are diabetics may present totally different. And one of the things we're seeing is women tend to present differently than men in complaints. And women a lot of times will complain more of fatigue, generalized chest pain, but not as specific, not that sitting on the chest, heavy pressure and radiation. So chest pain has to be taken. Don't blow it off because they say they don't have that heavy pressure, that it's not radiating, especially when you're looking at patients who are diabetic or patients who are taking beta blockers or women. All of those can present in different fashions with these patients. Of course, the 12-lead EKG, we're looking for that ST segment elevation. But if this patient has a non-STEMI, we may not see that on the EKG. And then with labs, we're going to be looking at cardiac biomarkers. Typically, what you're going to see in most facilities are troponin and CKMB, creatine kinase myocardial bands. Your book talks about some radiology, thallium scans, and contrast-enhanced MRIs. Most of the time, you're not going to see this. This may be done later on, but typically in your emergency departments, these three right here, signs and symptoms, 12-lead, in your labs, are going to tell you whether this patient has had an MI or not. Again, I don't know why that one's there. I apologize. Now, one of the things you're going to need to know for the test, and you're going to need to know for practice, is how to do a 12-lead EKG. Placement of the leads is very important as we begin to look at doing that EKG, because we're trying to look at that heart at a specific angle with the electrical activity. V1, okay, V1 goes at the fourth intercostal space at the right sternal border. V2, fourth intercostal space, left sternal border. We put V1 on, V2, then we move over and put on V4. V4 basically is at the fifth intercostal space at the mid-clavicular line. Let me get my pointer here. So you can see here, this is 1. So we're going to do 1, 2, and 4. So we're going to find that mid-clavicular line, fifth intercostal space. Then we're going to put on V3. V3 basically goes halfway between V4 and V2. Okay? Then we can put on V5, V6, okay. Way I was taught to put on V6 first, which is basically at the fifth intercostal space, the mid-axillary line, and then V5 actually went halfway between V5, being V4, and V6. Now here they're telling you to measure horizontally to the fifth intercostal space at the anterior axillary line. If you'll just go halfway between V5 and V4 and V6 and put V5, you'll be okay with that. Of course, there's leads goes right on the arms and the legs, so you have 10 leads hooked up to this patient to look at that 12-lead EKG. Here it talks about the right arm, right leg type process. Now, it can go on the shoulders, on the thighs, it can go arms, legs. The main thing is when you do a repeat EKG, make sure you're putting the leads in the same area. So with that patient, that you're actually getting the same look at the heart each time you do an EKG on them. Most of the time you're going to leave those leads in place, especially in the emergency department or whatever, so that they're there. So if you have to do a repeat, you can repeat those areas. So, but you will be testing on actually putting on 12-lead EKGs for these patients. Again, we've talked about this already, looking at the infarcts, basically inferior leads, and lead 2, 3, and AVF indicate inferior changes. Anterior, V1 through V4, and lateral, you're seeing things. Again, what we're looking for is basically either ST depression or ST elevation on these patients. If you see a Q wave is an older injury. But as a nurse, you will not have to read a 12-lead EKG for me. I know the paramedics have to learn that as part of their training, but as a new nurse, reading a 12-lead EKG is not one of the things that you'll have to do. Now, what I would like you to be able to do is recognize that something is wrong when you look at the EKG. If you see this large, basically, ST segment on this patient, then you know something is wrong. You can see this severe elevation on these patients. you understand, hey, this is an emergency. I need to get this taken care of as quickly as possible. You can see here in lead 2, you can see the ST depression. Go down to lead 3, you see the ST inversion here, but you get over to V1, V2, and V3, you can see that severe ST elevation. That tells you something's wrong. I need to get the doctor immediately. This patient is having an MI. I don't care that as a nurse you can tell me that it's an anterior, inferior, or posterior. You just need to understand that what the ST depression, ST elevation means. Cardiac markers, the typical cardiac markers that we're going to look at are troponin. Troponin is broken down into troponin I and troponin T. And then you'll see a creatinine kinase and a creatinine kinase MB, which stands for MB band. Myoglobin, your book talks about, but I rarely see that done. In some of the areas you may see it, but most of the time you're going to be looking at troponin and CK-MB to diagnose your MI. Now, troponin is a myocardial muscle protein. It's released into the bloodstream when there's injury to the myocardial muscle. At Huntsville, you'll be seeing troponin I used instead of troponin T. When you look at troponin T, normal value is less than 0.20 nanograms per milliliter. And when you look at troponin I, it's less than 0.03 nanograms per milliliter. Timing of these, they're released within 3 to 4 hours after injury. Typically will peak out, even though the book says 4 to 24 hours, most of the time you're going to see them peaking more closer to the 12 to 24 hour period. It does take them 1 to 3 weeks to go back to the normal ranges, but again, what we're doing when we're doing cardiac markers, we'll draw cardiac markers when this patient comes into the emergency department, and then we'll repeat them every 8 hours times 2 to see how these markers are rising or falling depending on what time frame that patient says they began with the chest pain. Oops, went the wrong way. Okay. Creatinine kinase is an enzyme specific to the heart, brain, and skeletal muscles. Its appearance in the serum indicates tissue necrosis or injuries. So if you just see an elevated CK, it could be brain, muscle, or heart. So you really don't know if you just see that elevated CK. You go out and work hard one day and you're not used to working real hard, use your muscles, exercise, you can see an elevation of the CK. So there are different bands of the CK. There's bands for the brain, bands for the muscle, and bands for the myocardial muscle. So basically what we're going to be looking at is the CK-MB. Now the CK-MB 1 and 2s, most places we're just going to say CK-MB. And typical values are 3 nanograms per milliliter. And a relative index of greater than 2.5 is indicative of an MI. That relative index is basically kind of a ratio between your CK and your CK-MB. So if it's greater than 2.5, then you're pretty sure that you've had an MI. CK-MB rises 3 to 6 hours after an infarction, peaks somewhere around 12 to 24, and typically returns to normal in 24 to 48 hours. Myoglobin, again, your book talks about, is a low molecular weight hemiprotein found in cardiac and skeletal muscles. It's more sensitive, more specific as you look at the markers. Normal values, less than 90 micrograms per liter. Rises basically 2 hours after an MI and then quickly declines. So if that patient came in very early, then you might see this, but if the chest pain's been going on longer than 12 hours, you may not see this elevated. Again, not something I see done very often in practice. This just kind of gives you an idea as you look at the different ones. Your blue is your myoglobin, your green is your CK-MB, the red color is your troponin. And you can see with the troponin, it begins to go up, goes up, peaks. Somewhere, they've got it peaking somewhere around the 3 to 6 hour range and then begins to drop back down. And usually after 2 days is when you really see it begin to drop. So it's going to remain elevated. When you look at the CK-MB here, it kind of goes up. It's going to peak somewhere around that 24 hour period and then actually begin to drop back down. So when we're looking at it, we're looking at the CKMBs and the troponins. We're watching them. That gives us an idea of how long the patient had problems, but elevations of those will indicate an MI. Just another graphic representation of that. Now, typically you're going to draw a CBC on these patients as part of your normal profile, just like you're going to draw electrolytes on these patients. Real important to know that basically if this patient has a severely low H&H, it can make things worse because you lack that oxygen carrying capability. So you need that oxygen getting to the things. Again, I think I said this earlier, but it's not uncommon for patients after they've had an MI to have an elevated white count, as well as having a slight temperature, because the inflammatory process is taking place in that heart muscle. So an elevated white count plus a slightly elevated temperature is not uncommon in these patients. Again, we need to monitor the electrolytes. Hypokalemia can lead to increased electrical, that should say instability, not stability. Can lead to ventricular dysrhythmias and increased risk of digoxin toxicity if that patient has been on digoxin. Hyperkalemia can lead to slow ventricular conduction. Calcium, again, very important. Hypocalcemia leads to ventricular dysrhythmias. Prolonged QT intervals. And those prolonged QT intervals are important as we begin to look at PVCs, because if we get an ectopic beat hitting on the T wave, our patient can then be sent into VTAC or VFib. Hypercalcemia is going to shorten that QT interval and may lead to AV blocks on these patients. Magnesium, very important. Low magnesium can definitely lead to ventricular tachycardia, to something called torsades de pointes. And really to treat that, you've got to get those patients that magnesium they need. Be very careful in patients who may be alcoholic, because lack of nutrition, you may see some of these problems in these patients more likely. Chest x-ray is probably going to be done on your patient, typically more to look for signs of CHF and look at the heart size itself. Chest x-ray is not going to diagnose an MI, but it gives you some ideas if there's complications going on. Echocardiogram is not going to be done right away for these patients, but may be done at a later time to look at valve movement. And then looking later is how much damage was done to that heart, what kind of wall movement do I have, how much ejection fraction do I have with this patient because of the damage to the heart. Let's take a break right there, and then I will talk about complications of an MI.